I don't know if we've got any members of the public with us yet. I can't see anybody, but for the purpose of the meeting, welcome to everyone. Welcome to the open session of the Bristol, Somerset, South Gloucestershire Integrated Care Board. We're scheduled to go from 1:45 until 4:45. Maybe we won't be quite that long, but let's see how we get on. I've got some apologies. So I've got Nick Hibbard from Bristol Council, Dominic Giusti from AWP, but I think Alison's with us, his deputy, John Martin from South West Ambulance Service, Dave Perry from South Gloucestershire Council, but Anne is with us. Joe Medhurst, Chief Medical Officer, but I think Paul Roy is with us for the item on the Deep End project update. Mark Cook from NHS, and I don't think we've got a replacement for him. Kevin Pelleton, Messenger from Health Watch, and Jen Bond, our Head of Communications. Rob, is there anyone else I've missed?
No, Chair. And just to say, in terms of members of the public, there's a Louisa McKenzie on the screen, is our member of the public who's joined.
Okay, thanks, and welcome. So, any declarations of interest that people haven't notified us of previously? Okay, thank you. So we've got the minutes of the meeting on the 1st of May. Can I just check if anybody's got any comments or observations on those minutes they'd like to raise? No? Okay, great. Thank you very much. So we've got 3 outstanding actions. The first one's around the ICS EDI report. Joe, anything to add on that? I think we've got a systems EDI group coming up, haven't we?
We do have a systems EDI group coming up, yes, and at the moment we are in the process of collating our system EDI data for 24-25. So further reports to come to the board over the summer months and into the autumn, Chair.
Okay, thanks, Joe, and we'll keep that as a running item if we can. And then we've got Deb, update on progress of BNSSG, innovation, improvement and transformation. So I've just been sent a written update on that. So you've done a bit of work on it. I don't know whether you want to do a very quick update.
Yeah, so since the April board, we've been working with the chief execs through the system executive group. We've had probably 4 or 5 meetings in relation to the whole piece. One piece looking at the transformation load and the transformation resources that we've got. So there's now a single report that's been shared with SEG. We haven't had a chance to have a discussion about that in detail yet, but I expect we'll have some revisions. And then we've spent significant amounts of time on the leadership compact, which was the kind of core part of the conversation that we had at the April board. And there've been 2 in-depth workshops, and we've now got a draft, and we're just reinforcing that, revising that with each of the chief execs, with a view that we agree in September and come back to board for endorsement.
Okay, that's
Shane,
great.
I don't know if there's anything else you want to add on that.
No, nothing further to add. It's work in progress, but it's been quite an engaging piece of work so far, Chair.
Okay, lovely. Thank you both. And then the final one was around Joe Medhurst looking at organisational memory in the Integrated Care Partnership update. I can't quite remember what we asked her to do there, and the action's not closed. So, Rob, I would suggest we close that as an action. It's on my agenda anyway. So, Rob.
Some reassurance, Chair. So leavers checklists that we have in operation when people depart require the handover of relevant documentation and information. Of course, you're never quite able to nuance everything and every conversation, etc. So I think you're right. I think we can close this, and we just build this into our organisational develop as we go forward. Okay, thanks, Rob. So just a couple of things before I pass over to Shane for the Chief Exec's report. The first one is I mentioned at private board, but it's Sarah Truelove's last open board with us as our Deputy Chief Exec and Director of Finance or Chief Finance Officer.
So again, Sarah, I said it this morning, but a big thank you to you. You've made a major contribution to us as a group here in BNSSG, and long may that continue with the new role in Gloucestershire as well. So thank you.
Thank you, James.
Okay, and then the second one is just around, I know a message will have come out from Rob this morning to board members about declarations of interest. It's quite a quick form to fill out unless you've got lots of them. Can you make sure you fill that out for us so that we have got any declarations of interest recorded? Thanks very much. Okay, let me move us on then to Chief Exec's report. Shane.
Thank you, Chair. And colleagues, as always, it's a relatively short report, 3 big things. Quite clearly, there is a remarkably big thing today, which is obviously the 10-year plan, which hit people's desks this morning. Clearly not part of my paper, due to the fact that papers had to be produced in advance of this morning. But I think it is important to note we will do a lot of work in getting back to the board and understanding the 10-year plan, what does it mean, etc., when we have digested it. But a very important piece of information. What I have in my report today are 3 big things. One is where we're going with organisational change, so our direction transformation. The second one is winter planning, because actually that's fundamentally important, and we can't let things like that be distracted by a lot of the organisational change going on. And then the final part, which is about Healthier Together 2040 and the importance of that in strategic commissioning. I won't obviously read through the paper line by line, Chair. Everyone has a copy of it. Just pick out a couple of things. The first one with regards to the transformation and our change process. As you will see from the paper, the proposal was that we, BNSSG, would cluster with Gloucestershire ICB. That is now approved, and therefore that will be the case. We'll be moving forward to cluster with Gloucestershire ICB. We're in the process now of working through appointment of chair, appointment of chief executive, and the governance structures, and we'll bring that formally back, obviously, in closed and open sessions. But I think it's important that we now have clarity. That is where we're going, and we're now in the process of putting together all the pieces of the jigsaw. What I did call out in today's report is just so that everyone is aware from a board perspective, and also as this is a public document, is just to re-emphasize the future shape and style of the ICB based on its functions. And you can see quite clearly in the second page of my report the kinds of functions that we will grow as a new organisation, the kind of functions that will transfer to NHSE, and then the kind of functions that will transfer to other local providers. And a local provider doesn't just mean a single trust. It might mean a CIC, it might be the voluntary community sector, it might mean primary care, all kinds of things. And Chair, just to bring to the board's attention, quite clearly this is a major piece of work that we will be putting in over the next number of months to safely transfer those functions. It's not as simple as us closing the doors and expecting providers to pick it up. It's about looking at the transition process across. So that's the first big thing. The second big thing, and I think is important, is winter planning. I know it seems a bit strange, the sun is shining, it's the 3rd of July and we're talking about winter planning, but actually we must ensure we have a strong, well-tested winter plan. So you'll see in the paper we've called out some core responsibilities for an ICB around vaccination uptake, around community services, about admission avoidance, and really, you know, being that system coordinator. But this is about a whole system approach to winter planning, all providers working as one system. And what's clear is that we will have to work over that the next month to 2 months. We will be expected to do a full desktop review and some forms of simulation to check our plan would work, push it to extremes. What if flu ended up looking like this, not like that? What if we had massive surges, etc.? What if we had staff illness? And we'll be asked to then, through NHSE, to really drive and test a winter plan. Obviously, that winter plan will need to be signed off here. It will then need to be issued to NHSE, and we need to make sure the stress testing happens in September so that we're all absolutely ready for winter. And we're doing it really early this year for obvious reasons, because actually there's no point planning for winter when you're in winter. You make sure you do it well in advance of winter. And the final thing I want to raise to the board's attention, and we did discuss this at closed session today, Chair, is the importance of the piece of work we call Healthier 2040. And 2040 is a piece of work for us to really understand what our population looks like, identify certain cohorts, and begin to go really deep in an understanding of what those cohorts need and what services we could put in place to really begin to shape our population so that by 2040 we can have people who are living longer, healthier lives, as opposed to what the predictions actually tell us at the moment is that people will live longer, but they won't live longer, healthier lives. They'll live longer, unhealthier lives. And 2040 is a massive piece of work. And the reason why it's so important today for me to put it in my report is because actually as we go through all of this change, and we'll be going through a lot of change in the next 6 to 9 months, 2040 is our blueprint for strategic commissioning. It's how we would intend to create the new organisation based around the learning we've taken from our 2040 work chair. So I say I wasn't going to read it word for word. Happy to take any thoughts, comments or questions that any board member may have, Chair.
Okay, thank you, Shane. Any comments or questions for Shane on his report? Alison.
Yeah, thanks, Shane. Thank you. I always appreciate the 3 big things that are in your mind that you share with us. I just wanted to pick up winter planning, and I completely agree with you that we can't get distracted through the organisational change about the things that we need to do. But there is a question, isn't there, about any potential impact or risks from organisational change in derailing us from being able to focus on the things that we want to do. Just two questions. How can you give any reassurance on that? But secondly, what can committees or the board do to help, perhaps if areas need to be prioritised or deprioritised? So I quite agree with you, we can't be distracted, but it's easier said than done sometimes. So what's your sense of the risks, and how can we help, if at all?
So thank you, Alison. So what I've asked executive team colleagues to do is to look at the next 6 months and see the things that absolutely we must do versus the things that we might have done. Okay, so it's really important to narrow down. So we know as we go through this turbulence, and it will be turbulence, people will choose to leave, people will, not be part of the process, people will be distracted. Okay, so narrow down our core business. Winter is one of our pieces of core business. So ultimately, we've been told very clearly by NHS for 25-26, the ICB is responsible for winter planning and winter coordination. And therefore, I am asking executive team members to look at what other things could we park to make sure the organisation can be focused on a smaller number of key issues that need to be dealt with. I would then probably need to work through the chair and the committee to say, therefore, committees, can I please ask you to focus on these things as opposed to these things, because they're the ones that we see as key and important. Because there is no doubt we will not get through the next 6 to 9 months without having considerable impact from this process. We'll have people leave, people distracted. So we'll try and narrow the portfolio for the next 6 months. So the organisational plan, as in delivering our plan, and part of the delivery of plan is winter planning. So narrowing to try and make that work for us. But we will reassess, and we are reassessing our risk register for the transition regularly, because if we start to see some things start to go off, we might have to narrow it even further. Alison.
Thanks, Shane. Thanks, Alison. Aisha.
Thanks, Shane. Thanks, Jeff. Just another question, I guess, around winter planning. And thank you for the comprehensive report. I note that it says that the winter plan will build on last year's learning and includes lots of different sort of improvements which have been identified, but we know that urgent emergency care can be quite complex and challenging. So I guess appreciating that we are starting the process quite early, what reassurance could you give that the plan will deliver materially different outcomes this year compared to last?
Yeah, I mean, I think it's really important. We have a great team across the system led up by Dave. And I'll ask Dave to come in to give a little bit more detail, because we are going to have to bring the whole winter plan through. But we've really critically looked at the key challenge. We still have no criteria to reside. Okay, let's put it on the table. No matter which way we look at it, no criteria to reside. Dave and his team have done a huge amount of work to really get underneath that and have a system agreed plan for moving forward. But I know, Dave, you want to sort of give a little bit of flavour to that.
Sure. So I think it's not just me and my team, and we had the partnership working that's sitting behind our urgent emergency care plan and our
community discharge plan, Aisha. I can't tell you how many partners are generally embedded and within it. And we are seeing leads from, I've got a lead from North Bristol Trust who's now heading up a community beds work stream. So partners kind of working across each other. I think in terms of a different model for next year is going to be the stress testing of the winter plan in a way that we haven't done in recent years. So making sure that our plans are robust, in normal, in peak flu, and in absolute extremis. And there'll be a very clear process for doing that. And I think making sure that it's not just community flow, but we have plans around our vaccinations. We have plans in place for children and young people. So we're looking at the whole breadth of urgent emergency care services into winter and then testing it to the hilt. That would be the key difference this year.
Okay, thank you, Dave. Thank you, Shane. Ellen.
Thanks, Jeff. Thanks for that update, Shane. So just quickly on winter plan, it's something that the Outcomes Quality and Performance Committee is going to be looking at in the next few weeks, and it's sort of, we made it our main agenda item. So I'm hoping that will be useful for the board in terms of pushing and prodding and just taking that assurance. I'll come to some other points in my update later on. But Shane, my other question was around the transformation. Obviously, there's functions to transfer to NHSE and then local providers. Could you just talk about the progress you're making with NHSE region and how comfortable the progress is in moving some of our current functions to the regional function?
I suppose two things to raise. One is I've been on leave for the last 10 days, and this world is moving so quickly that I might say something that Sarah might say, no, you weren't in the meeting last Wednesday. Okay, so I just think it's important just to clarify. The region have established a thing which is looking at the model region. Okay. That model region is looking at what functions the region would have, and also then proposals for how it would receive those functions into NHSE. Okay. And certainly when I went on holiday 10 days ago, that's where it's stated. I don't know whether Sarah, there's been any further on the model region. From reading from my stuff, I don't see a huge amount more in the model region, but I don't know, Sarah, your involvement in some of the meetings last week.
So no, there hasn't been any formal update on the model region. The work is ongoing, but we haven't had that formally received yet.
But they are, so that's what they're working on. They're creating an equivalent to the model ICB for the model region, and then begin to look at how do you transition those services across into that space. They've set up a number of work streams, and they're hopefully working on it. The point being is that we can't become the ICB we need to become unless we're certain that there's someone there to receive those services into the future. Yeah,
I'm just conscious that over August, September, October, when there's going to be a lot of sort of organizational change, that that we might struggle to perform these functions at that time. So I'm just thinking of the urgency of it, right? I fully understand, Shane, that it's not necessarily in your hands at the moment, but thanks.
Thank you. Thanks, Ellen. Fiona.
Yeah, thank you. Just building on Ellen's question around transformation, and mine's more an observation. I appreciate that we haven't had, it's the devil's in the detail, but again, just looking at the transfer of functions, and then particularly the data collection and the research and innovation that's been placed in NHSE region. My observation is that that's going to prove difficult to do at a regional level. Because we're going to lose sight of local knowledge, and I'm just sort of, my crystal ball, just thinking that that's going to be happening at all levels, and particularly in relation to the neighbourhood plans and how we develop there. So just an observation that it's not as easy just to move that function to regional.
And if I can, Fiona, I know it's a public meeting and therefore be a matter of public record. I think the conversation we'll get into with NHSE will mean that we cannot be a world-class commissioner without owning research, without owning innovation, without owning data collection. And I think that that's where we'll start from. Okay. because I think if we're going to be a really great commissioner, you've got to bring research into practice, practice into strategy. That's just the way it has to be, and therefore I do not envisage research and innovation being a NHSE function. I think that's a really important function of the ICB of the future.
Okay, thanks, Fiona. Thanks, Shane. Any other comments or questions for Shane? Okay, let me move us on to the corporate and strategic risk registers then. Shane, I think you're picking this up.
Yeah, thank you very much, Chair. So, Chair, I know I will ask Rob to come in to talk a bit more detail, but obviously you've got the papers. Colleagues, apologies, the risk registers are just so illegible on Diligent, and we've got to find a better way to do that. So apologies. And I think what we'll do in future is, and I know we have sent documents out since, but in future we'll find a better way to put it on the screen. There are two sets of registers there. One is the corporate risk register, one strategic risk register. So corporate is about the ICB, the organization. Strategic is about the system. Okay, so what we are asking today of board members with regards to the corporate risk register is for you to be aware of those risks that are coming off the risk register and those that are coming onto the register, and they come up through the ICB, the organisation, through the directorates, where a strategic risk register is the chief executives collectively looking across the ICS and saying, actually, what are the big risks and how do we need to manage them? So they're two separate things, but obviously connected, but they are two separate things. So I don't know that, Rob, you want to just quick input on what you're asking of us today, but it is very much about new risks, old risks, and then understanding where the chief executives are at. But I don't know, Rob, you want to add any more on that before take questions?
Thank you, Shane. And yes, today the two risk registers that we're looking at, which Shane has described, we're asking that the board receives the attached the corporate risk register, notes the details, which I'm going to just touch on in a moment, accept the risks that are escalated, and approve the closure or the de-escalation of risks where those are also indicated. There's also, just to receive and note, the ICS strategic risk register. So these documents have already been received by the Audit and Risk Committee through at their meeting in June. And of course, there is always, as we know, an issue of timing in regard to when risk registers are produced and then the pulling together of corporate risk registers, etc. So bearing that in mind, as I say, Audit and Risk Committee have seen these risks. And prior to that, the executive management team of the ICB and the system executive group have had input to the updates. In regard to the corporate risk registers, 16 risks included on there, and some of them are and all of them are scoring 15 and above. That's the criterion in the directorate risk registers as set out in the risk management framework. That means that they come onto the corporate risk register. Of those that are shown, some have been recommended to the board for closure because the risks have de-escalated to below 15, and they are the risk around primary care development and the lack of capacity. The risk around the urgent and emergency care risk and access to services regarding the temporary closure to the Broadmead Walk-in Centre. Risk around the high costs associated with high cost drugs, procurement capacity in the medicines optimization team, which has been moderated down, and then the risk around primary care data sharing and the impact that would have been had on information as a result of collective action. So those are the risks that are recommended for removal from the corporate risk register. Those that have increased in their number and are now added to the corporate risk register are both of them around potential overspends. One linked to the variable activity on elective care, which could affect the financial position, and that's around their commissioners not having the mechanisms to limit activities, but having fixed allocations, and similarly around variable activity on ADHD and autism, and that affecting the overall financial position of the ICB. So, Chair, that's the updates that I bring you. Oh, sorry, if there's one other point to note, and this isn't in the paper and it's not included, but the risks associated with the system executive group, those have been those are presented, sorry, this is presented, and they include a new risk which has been added around the impact of the NHS changes on future ICS performance, and as I think Shane has alluded to in his as I know Shane has alluded to in his CEO report, you know, this is moving at quite fast pace, etc. So this is one of those risks that the system has recognised, and we will need to take a view on going forward in how we choose to continue to mitigate that. Chair, that's my update.
Okay, thanks, Rob. So you've had those papers circulated on both the corporate and strategic risks. Any comments, questions for Shane or for Rob? So the recommendations are fairly clear. Ellen?
Yeah, can I just first of all, so I'm talking about the strategic risk register rather than the corporate. Can I first of all just thank you for allocating those to committees? So I think that's a new, I think we'd asked for that, and I think you've referenced the committee that should be looking at that risk. To that point, for example, flow is, you know, we've just been talking about flow, talking about winter planning. This is quite an urgent risk, I would probably say. I think it's really important now that within the papers of the committee that those risks are presented as a paper to support the conversation that will be going on. So, for example, if winter planning is a key agenda item, then this risk and its mitigation should be put on there for testing during the committee meeting. So, for example, I've got a number of questions on that particular risks in terms of mitigations. I'll keep those for the Outcomes Quality and Performance Committee, but I just think it's important to bring those two things together. Thanks, Jeff.
Okay, thanks, Ellen. Any other comments or questions?
Can I just say, Jeff, that's exceptionally helpful, and that helps us close the loop back to this board, that we're actually testing our actions, not just looking at a register. We're poking and prodding at the actions we're taking to make sure they are the right actions as well. So thank you, Ellen. That makes an awful lot of sense. We need to make sure we get into that rigor then with all of them. That's really helpful.
Okay, thanks. Alison?
Yeah, thanks very much. I'm on the strategic risk register as well. The new risk on the impact of the NHS reforms and ICS, which the overseeing committees of this board. And I know it's emerging. I know there's always a time lag and it's a new risk. But in terms of the risk as described, the mitigation appears to be the setting up of the transition committee. So I just wanted to check that the terms of reference of any transition committee will be able to, in their entirety, if you like, help to mitigate that risk, or is there anything else as well? So just making sure those two are lined up.
Shane, do you want to pick that up, or I can otherwise?
Certainly. So in terms of what we have created in the interim is a complete risk register about the transition process, and we use that between ourselves and Gloucestershire to see whether we're managing the process well. So probably what we would have had in that column is not just the creation of the committee, but all the actions we're taking in that risk register. We haven't pulled that through, but it might be a good addendum to have for the next time we bring this to the board, so all board members can see the actions we are taking. Now, once we have the committee established, that in itself will be, you know, it'll be minuted and all that kind of stuff. So therefore you'll have a set of evidence to show the committee is working. But at the moment, what we do have is a standalone risk register that we have pulled together with myself and Sarah and Mary in Gloucestershire to create a risk register. So probably the one you have in front of you probably doesn't articulate that as clearly as the work we have. And maybe what we'll try and do, Alison, is make sure that's clearer. But you're dead right. The absolute mitigation and control in this will be the new transition committee.
Okay, thanks, Shane. Any other comments or questions? So can I take them individually then? The strategic risk register, is there anybody who's not happy with the recommendations that we've had presented to us? Okay, thank you. And then the corporate risk register, likewise, is there anything on there that people want to ask any further questions or aren't happy with the recommendations? No? Okay, in that case, I'll move us on to the green plan refresh then, Sarah.
Thanks, Chair. So this is NHS England have asked all NHS organisations to refresh their green plans by the end of July. So this is bringing that to you here. But I think it is really helpful point for us to do that refresh and to sort of take into account changing policy as part of that. This is one of those areas where the ICB blueprint suggests that this transfers to providers, and I just want to recognise first of all that this is work that's already carried out. Sam Willits, who works in MBT but does this work on behalf of the whole system, and I hope that you'll see that I think this is a fantastic example of where we've managed to embed it in everything that we're doing across the system. We've taken a really sort of proactive approach in building this into our operational planning process. It's been one of those challenge questions because the response to the climate emergency needs to be everybody's business and to come into all of our plans, because you'll see it is really comprehensive in terms of the areas that we're focusing on. Probably the biggest change in this plan is what we've tried to do is to separate it into sort of two tranches, the things that are directly within our control. Where we are committing absolutely to reducing our to getting to zero carbon by 2030, and then those things where we're not in direct control and therefore we're going with the national sort of timeframes, which are still significant reductions by 2030, but not getting there in total. The other things that I just wanted to draw out of this for you is you'll see in the ambition we talk about wanting to be leaders in this, and I think that this is an area where we really are leading the rest of the country, and we should be really pleased with that. This plan will follow in sort of in the autumn. There will also be an update in terms of the detailed delivery plan, particularly for the emissions where we are in direct control. So that is working through. Section 15 really draws out the fact and sort of ties this into the work we're doing on Healthier Together 2040. The biggest impact we can have on reducing the impact of our services is by being more preventative. So it really ties into that the shifts that we've already talked about that we're trying to really keep the focus on in terms of intervening earlier and being more proactive in our care models. Just under workforce and leadership, the one thing I particularly wanted to draw the board's attention to is one of the actions is that we will want to work with the board to get some time to do some carbon literacy training for the whole board. That's one of the commitments that we're making in the plan. So I hope you will agree to that, and we will arrange that then in due course. The other thing, just the final thing that I wanted to, oh good, Sam is joining, so that he can answer any difficult questions. The other thing that I just did want to draw out is just the finance and resourcing. One of the things we did up front as part of the capital prioritisation is we have had an amount, £3 million that we've been using, basically giving control of that resource over to the Green Plan Steering Group, so that they've been able to prioritise the use of that, both to leverage in further investment, and they've done that really successfully, but also sort of agnostic to the organisation that we're talking about, but really leveraging the best we can in terms of maximising carbon reduction from that resource. We know that there are changes coming up now in terms of the availability of Salix grants, and but this is an area where the government have proposed that we will be able to they are developing sort of private finance initiatives. So this will be an area where we'll want to focus quite a bit of attention to make sure that we really are able to deliver on all of our ambitions, because we're able to secure the funding to do so. So really pleased to recommend this to the board. It is also going to our partner organisation board meetings over the next few weeks, so that by the end of the month it will have been signed off by everybody. The one other thing I'd just draw your attention to, because I meant to do that earlier, was just the engagement that there's been with the community leadership panel on climate change and just transition. I think it's really great that we've had that engagement with our communities to get their input into this plan, and you'll see that woven through the various chapters. So I think I'll stop there, and then if people have questions, Sam is also on the call, who has done all of this amazing work and will be very happy to answer any questions.
Okay, thanks, Sarah. And you can see it's a very comprehensive paper outlining what we've done. So thanks for that, and thank you for the summary and the update you gave there. But let me open for questions. Jaya.
Yeah, thank you, and thanks very much for. It is a comprehensive report, and it's really good to see all of the things that are being kept on in terms of focus. Did wonder, I'm sure there was something that was in there before in previous plans in terms of communications, not in terms of communicating the plan or with suppliers, but actually paper communications between our primary care partners and residents, because I know there's still a lot of paperwork going back and forth, and I didn't know if that was part of this tranche or if it's, if it's in hand somewhere else.
So that is within the digital area. We haven't specifically talked about paper, but it's within the efficiencies that we're expecting digital side to deliver. So it's I suppose it's quite a broad area of saying we're going to improve efficiencies and things like that. But what we're trying to do is actually make sure we're capturing the benefits of where we are doing that work, and so encourage it on. So a lot, there's all sorts happening in the digital sphere. So where we know that there is carbon reduction benefits and paper benefits or travel debt benefits, that's where we're trying to make sure that is being captured through those projects, which will then reinforce actually doing more of them.
Okay, thanks, Samuel. Thanks, Jay. Any other comments or questions? No. Okay. So Sarah, I mean, obviously, as we enter the new world about what the responsibilities of the ICB are, how this is positioned might change. But for now, we're asking whether people are happy to agree what's proposed as the way forward with the Green Plan. Is there any dissenting voices to that? No. Okay. Great. Thank you very much. I'll move us on to the next item then, which is the Deep End project update. And I think, Paul, you're stepping in for Joe Meadows to give us the update on it.
I don't think Paul's joining us, but I have just sent a message to say we're ready for him.
Okay. Do you want to move us on to committee updates then, and we'll come back when he arrives with us. So, Ellen, Outcomes, Quality and Performance Committee.
Thanks, Jeff. This is the update from Outcomes, Quality and Performance Committee meeting on the 27th of May. We received a report from the CMO with a focus on women's health, national medicine shortages and GP collective action. We received a quality report with a focus on paediatric audiology, a very positive visit from ICB and NHS, and a Q4 safeguarding report. In terms of safeguarding, it's really good to see such a strong team who are working system-wide to push the agenda forward. They built relationships and they have a really comprehensive plan of work. The report they produced was on 3 key areas: themes and trends relating to safeguarding work programme, identified risks and mitigations, and also examples of transformation. In terms of the quality report, we heard of 2 key areas of slight concern, which is the number of C. diff cases nationally have risen to their highest level in more than a decade, and BNSSG mirrors this pattern. The system is working on a wider project with NHS Southwest to understand the drivers, and I'll ask Rosie to come in the end if there's anything she feels she needs to add. MRSA is also a concern, with BNSG being a little bit of an outlier, with 4.06 per 100k population compared to England at 1.73 and the Southwest at 2.01. So this is an area of focus, and the team are focused on understanding and taking action, including annual retrospective reviews. In terms of performance, there's some really encouraging performance on elective and cancer, if I compare where we were sort of a couple of years ago. Urgent care is also good, with category 2 ambulance just slightly off target, but very much on track. And our 4-hour A&E performance is ahead of target, which is really good, and towards the top of the country. So all of that sort of really looking good at the moment. I'm going to talk about the area that I probably always talk about, which is no criteria to reside and flow. Shane has just mentioned that it continues to be a challenge for the system. I think Ruth earlier mentioned that winter and how we support our frail and elderly are really important. And in the context of looking ahead to winter, we're still struggling even when we're not in winter. So against a target of 15%, we've got MBT with no criteria to reside at 21%, UHBW at 23%, and Western at 36%. So we've not managed to move that. We're also one of the most challenged systems in the whole of England. We've got some fantastic teams producing really good initiative, but regardless of that, we don't seem to be moving the dial. So I was pleased to hear that we've got some new initiatives for next winter. At our last OQP meeting, Sue Balcom, who is the non-exec director and chair of quality at UHBW, offered a great deal of challenge and support to the executive team, and she agreed to meet with Dave's team, I think Caroline and Greg, to discuss what she sees as opportunity. So I'm hoping that meeting will have taken place in advance of our next meeting. My challenge to ICB executives and system leaders, as I always will do, is what's going to be different next time. I think Aisha sort of mentioned it earlier on. How do we know that we're going to be better than we were last year in winter? Questions: do we fully understand the problem? Are system leaders being honest enough with partners? I'm really interested in the work, Dave, that you mentioned on NBT community beds and the work stream that you've got there. I'd be interested to understand more of that at the committee. And is the decision making at a sufficiently high level so that we can really make the shift? So I know the work will be done in the middle of the organisation, but are we also looking sort of at the top of the organisation? So Jeff, that's my general summary. I'm still on no criteria to reside, which I think we should be, because we go into planning for winter. I don't know whether Rosie or Dave wanted to come in on any of the points that I've raised.
Okay, thanks, Ellen. That's very comprehensive. So Dave first, and then Rosie.
Thanks, Chair and Ellen. So I don't want to go into the details of all the different initiatives and schemes here, but recognising the position specifically on no criteria to reside that Ellen has just alluded to. What I did want to say is what we are doing and have done for this year is enhanced our scrutiny and governance of the delivery of our plans, and also the granularity of the plans and trajectories within that. So we have very clear length of stay trajectories. We have a trajectory specifically on no criteria to reside. We will be holding that to account through a kind of refocused and refined executive meeting that I chair, which will report both into system executive and the performance and recovery board, because delivery against this is key not only for winter but our overall operational plan, and therefore we've broken all of it down into a much greater level of granularity this year, and we'll be holding each other to account for that and course correcting as soon as it veers anywhere off that plan.
Okay, thanks, Dave. Rosie, anything for yourself?
No, I mean, as Ellen said, the two areas of focus around healthcare acquired infection are being worked on closely with region to try and understand them. The issue with MRSA has been a system issue for a long time and relates to some of our homeless population. So working closely with the public health colleagues about that. But that work continues. Thank you.
Okay, thanks, Rosie.
And just to let you know, Paul's here now, by the way.
Yeah, I've got that. Any questions for Ellen, Dave, or Rosie around qualities and outcome? Rob?
It's not a question, Chair. It's to note that the leader framework, which went through the Outcomes, Quality and Performance Committee, is here, and in line with the scheme of reservation and delegation, it needs to be signed off by the board or by the chief executive, in this case the board, and therefore it's here for the boards to be cited on, not necessarily discussed because it's been through the committee. But could we agree it, please?
Okay, thanks, Rob. And the paper's there attached. Hopefully you had a chance to read it. Any comments on that? It's being discussed at the committee, but any issues around the update of the policy? No. Okay, great. Thanks very much. Let's go back then to the Deep End project update. And I think Paul's joined us. Welcome, Paul. I think you're deputising for Joe Medhurst today, and you're going to give us a quick update.
Yeah. So myself and Beth Wynne, GP from Charlotte Keel, are here to present. So if it's all right, I'll try sharing some slides. I've never done it this way before. Does that come up and show you?
Yeah, it's coming up.
Yeah, brilliant. Okay, great. So so for those who don't know me, I'm Paul Roy. I'm the Associate Director for Research for the ICB, and I thought it'd be really helpful to contextualise the work we're doing with the Deep End within the broader research programme and strategy that we've got. So obviously there's the context of the ICB blueprint, where research is, it says to transfer some of the elements around research to region. But also the ICBs are to retain and build strategic partnerships to improve population health. And I think our strategy that we've already got is doing this. But I think bear that in mind when you're listening to what I'm going to be presenting. So the aim of our research programme is for health and care research that makes a difference to those who need it most. So we're very good at doing lots of research, but does it make a difference? And certainly can it make a difference for those people with the greatest needs in our population? There's the inverse care law, which I'm sure you're all familiar with, where the people with the greatest needs receive the lowest amount of health and care resource. It's even starker with research. So those services which are delivering those care services to those people with the greatest needs tend to have by far the fewest research opportunities. So we need to at least level this out, if not flip that on its head. In thinking about how we support research as an ICB in our area, so it's worth noting that our research team is externally funded, but we apply the same kind of approach as we do as an ICB towards almost everything we do. The 4 C's that Shane talks about: coordinating, making the most of the resources which are available, making sure services are in place, making sure that the activities which are going on are safe and being done to the right level of governance in terms of international standards of research practice, and being the catalyst for change. So making sure that we are here to help those areas with the greatest need be research active. And looking at our integrated care system, the trusts, including AWP, including SWAST, they've got their own research and development teams, so they're fine, they're covered, and they're doing a really good job. So our ICB research team supports all those other settings and areas and population health research, filling those gaps. And we help with the very early idea stage of research, making sure that the ideas that are come up with from academics or from system partners, we're supporting them to connect with each other, the two worlds, so that we can get really co-produced pieces of work with our populations, all the way through. We support till making impact, which is getting the evidence embedded into practice as well. And on that, we apply a model of knowledge mobilization to everything we do. And knowledge mobilization is an academic term for transferring knowledge from one place to another. So the traditional model is that academia with its evidence will produce evidence, and that will be transferred into our health and care system. We believe that actually that's a two-way street, and you can't make influential evidence unless you've been working with the health system in developing the research plans. Otherwise, you're not working under the constraints that we're working under, and it won't fit. So we might have lots of evidence being produced, but not necessarily all that useful to us. And further than that, we think this is an ongoing, constant, iterative process. We don't want to wait till the very end of a research project, which might take 2 years to develop and get external funding to do. It takes 3 years to deliver, and then another year before a paper's published. We can't wait that long before we learn anything useful for our system. So it's very much a model whereby knowledge is transferred constantly between the academic teams and the ICB and the colleagues across the integrated care system. So we've got some problems with that. So we do have low inclusion within research at the moment. We did a recent study and found 95% of the participants in research from BNSSG area were white, 95% white, 65% women. They were mainly from affluent areas, and I think the average age was around mid-50s. These are not the people with the greatest needs in our health system. So we need to do proactive work to shift our research into those areas of the greatest needs. There's also a mismatch between research or portfolio nationally and the challenges that we are faced with. And I like this photo because it shows people in the exact same space. They might even be in the same topic area, but they're focusing on different things within that. So very much about aligning our work and our research colleagues to what we're focusing on. There is an underrepresentation of workforce, so there's a lot of opportunities in research for medics, fewer for nurses, even fewer for allied health professionals, and the voluntary sector and social care have even less than that. So again, it's about levelling the playing field, but that's challenging because there is a scarcity of resource for community-based health and care research. There's quite a lot of money in research, but not a lot of it in community-based. As an example, we've been working with Sirona from when they took on the contract in 2019 and up until 2024, they had received 0.1% of the research infrastructure funding support that UHBW had received, 0.1%. So that's the kind of level of funding that we're trying to operate and level the playing field. So we have a strategy which has just been launched recently as an ICB. It's got 5 pillars, and the deep end is very much in the targeting the greatest needs pillar. But we've also got radically diversifying health and care research, developing partnerships between academia and system colleagues at every single layer of our ICS. That's a bit on pause at the moment for obvious reasons while we sort out the challenge from NHS England. Accelerating research into practice, and I just wanted to highlight as well, seeing research as a means of generating resources for our integrated care system. So there's various ways we can do this, but a really useful model that we've got are shared roles between academia and the ICB. I looked into Professor Nikki Walsh, who's a physiotherapist. She's at University of West of England and been working with the ICB for quite a long while. For every pound that we've invested in her over the last 5 years, she's generated £9.60 in external research funding for projects which are meeting our system needs. So these are really resource generating roles that we can do in partnership with our universities. So our strategy funding, so we can do more of these kind of roles and generate more research, which then is a cycle of growth. I will skip over this because I don't want to take too much time from Beth, but focusing on the targeting the greatest needs pillar, we've got 2 main strands of investment. One's the Research Engagement Network, which is working with voluntary sector organisations who are supporting our ethnically minoritized communities. And we have standards of working for, I seem to have run out of slides, but we've got training and support for researchers to help them deliver research to the standards that are required for equitable and inclusive research. And the other main drive within this strategic pillar is the GPs at the deep end, which I will pass over to Beth. And if I can find my way to stop sharing.
Thank you, Paul.
She will tell you much more. Thank you.
I'll just share my slides. Bear with me 1 second. It's just. Okay, I have to share my screen because it doesn't want me to do that. Okay, can you all see my screen okay? Okay, great. Hello everyone, thank you very much for inviting me to speak today. For those of you I don't know, my name is Beth Wynne. I am a salaried GP at Charlotte Keel. I'm also the ICE Locality Partnership Health and Quality Lead and the co-lead for GPs at the Deep End Bristol with my colleague Shobha Dawson. I'm going to talk to you briefly today about what the GPs at the Deep End movement is and our project in Bristol. And then I'm going to outline how we are trying to approach the different issues and areas that we're trying to improve and the successes that we've had so far, and then talk about the Deep End as part of a research potential solution. The photo here is a contour, the analogy of the Deep End. So the idea of the Deep End was initially coined by our colleagues in Scotland with the idea that people, particularly GPs and clinicians serving patients in the most deprived areas of society, often find themselves treading water and trying to barely keep themselves afloat amongst the huge amounts of workload that they experience, and also because their patients tend to be much more complex, and dealing with these challenges and getting to the deep end and having enough time to take a deep dive into them and their wider social determinants of health can be such a challenge. So GPs at the Deep End was born, and the initial aim of it is to tackle health inequalities in primary care. I have had a long-term interest in health inequalities and have been lucky enough to work in New Zealand and Wales and Malawi and South Africa with different marginalised and inclusion health groups. And really the main stay of my focus to date has been working in inclusion health groups within the UK. And about 3 years ago, we decided to see whether or not we could get funding to launch a Deep End in Bristol, myself and my colleague Shobha Dawson, who's a senior researcher, because we realised there was such a need for it in this city. As you can see on the slide, there's flags illustrating the other Deep Ends that occur nationally. Our Deep End, if you see the map of Bristol, focuses on patients who live in the most deprived 15% of the UK using an index of multiple deprivation. And as Paul mentioned earlier, the idea is that the research tells us people who have the most health needs are the least likely to access healthcare, and there is a direct correlation between deprivation and lack of access to healthcare. And in the same way, there is also this inverse research law. And the idea of GPs at the Deep End is to tackle these huge inequalities in primary care. Bristol has got 15% of the population that actually lives within the most deprived 10% of areas in the UK, and we have got 20% of the population living in the poor, 15%, 20% living in the poorest 15%. And as you can see on the map there, the dark red areas correlate with the poorest index of multiple deprivation. So I work at Charlotte Keel in the dark red area above the Lawrence Hill and Easton in the centre of the map. Hartcliffe is one of the poorest areas which is in South Bristol. The deprivation there is really remarkable. It's the 7th poorest childhood mortality and morbidity in Europe, and it's one of the 100 poorest neighbourhoods in the UK. So although there's lots of wonderful and affluent areas in Bristol, there is also significant deprivation, and the levels of inequality between the areas are huge, with life expectancy post-COVID of 15 years difference between the most affluent and the poorest areas. So lots of work to be done. Just wanted to share this slide of an example practice. So my practice, Charlotte Keel, is a wonderful place to work. We serve a really culturally diverse group of patients. The challenge is to make those patients know that we are trying to advocate for them and do the best. Often when people are in really difficult situations with wider social determinants of health, making everything about their life hard, it's really hard to find anyone that you can trust. And often the patients, only have their GPs as their advocates. And so the relationships become, very close, and your need to advocate for your patients is far greater than in other areas, more affluent areas. So I'm just going to talk through how we work using this WHERE principle. So workforce, education, advocacy and research are the key themes that we've been focusing on. You can see on this graph here the surgeries that are included in our DPEN network. It's the 17 most deprived surgeries in BNSSG, as well as the Homeless Health and the Haven, which are 2 inclusion health services. So workforce is one of the key arms. Workforce and research, I would say, are the most important arms of our network. Workforce is vital because we know that although it's totally rewarding to work in one of these most deprived areas, there's much higher levels of burnout because of the secondary trauma you received and the undocumented workload that goes along with working with most deprived patients. So we've really tried to target this as a way of improving engagement of GPs and improving recruitment and retention with what has been, brilliant success so far. We have a health inequalities fellowship program, which we've run, which has been funded by the BNSSG Training Hub. The first year we had 6 fellows and the second year we had 7 fellows. Unfortunately, we're still on hold at the moment with NHS England working out what the funding will be for this year. But those posts have had remarkable success. We've had clinicians in the deep end who are funded 8 hours a week to work on a non-clinically on an area of need to reduce health inequalities, and the breadth has been amazing. One of my colleagues has made their surgery carbon neutral because we know of the huge effects that the climate crisis has, particularly on the most deprived people in our society. Another colleague has made a one-stop drug clinic for the opiate-dependent patients in their surgery, which is a holistic clinic where they have to go and not navigate any of the other access. So it really improves the access and their care. Another colleague became research active from an inactive practice and managed to do 8 studies in that year. Another one improved the uptake of preventative health screening. The cancer screening improved the cancer screening uptake by 200%. They have been really remarkable in the work that they've done and the amount of those individuals who managed to carry on that work long term rather than it being just a short term solution. What's also really special about the post is that when the feedback from the clinicians has been so positive that diversifying their week has allowed them to feel that they can better serve their population group. They feel less burnt out. They feel more dedicated to the clinical workload, having something else to focus on and having a feeling that they are affecting change. Another key arm of our workforce has been the Power Up projects, which we launched last year, thanks to funding from Joe Medhurst, which is looking at continued professional development. So we've made some small funding pots, which are between £3,000 and £5,000 for a clinician to work on one of the wider social determinants that frustrates them on a daily basis and target that. So we've had real success with one of the Power Up movement projects, which is between 3 of the inner city practices. And that project has been really successful. 100% of the people who have taken part would recommend it. There's been a 63% reduction in sick days taken. There's been a 55% reduction in pain. And it's been so well attended. That's looking at things like yoga for anxiety, moving more for some of our Somali children in the tower blocks, looking at reducing obesity through movement and connection. And again, the feedback from the GPs doing that work has also been really positive. Education is another important branch. The research from our colleagues in Dublin tells us that if you expose GPs to deprivation early on in their training, they are much more likely to continue to serve that group if they're appropriately supported. So we now have a deep end student selected component at Bristol University where people work in the deep end surgeries and have specific training, for example, related to domestic violence, drug use, as well as things like cultural competency and how to care best for our refugee and asylum seeker patients. We also have worked with the Training Hub on their HEFT programme, which is a health equity focused training programme that we asked to have spots for in Bristol, which is a programme that makes a GP's registrar training specific to deprivation. So again, you're exposed early doors about how to care for this patient group, and really builds this feeling of vocation, which is what so many of our GPs say that helps them serve the group long term. And finally, we have face-to-face events to sort of help boost morale and share ideas with clinicians and community members. You can see some of the visual minutes from our most recent ones. And we host 3 of these a year, and that really allows space for discussion, particularly around advocacy and research. As I alluded to before, advocacy is so key because our patients need to trust us and understand that we are trying our best in a difficult circumstance to do our best for them. And often people won't have much contact with other people in any kind of system. So being able to represent community voices is absolutely vital. We have established key relationships with 15 community organisations who engage and come to our face-to-face events, and also have valuable additions to PPI. So the patient engagement groups has been really important in looking at what are community priorities. Like Paul says, a lot of research goes on, but sometimes we're not asking or answering the questions that our community wants answered. So it's been really important to tease out those aims and work with our community in order to help advocate for them. And if research is, taking a while and they're not able to see results, we're often able to do a quality improvement project or something on a smaller scale and to help really show how much we're trying to do to help them achieve. And their insights have been valuable, and making sure we are working always in a trauma-informed way so that our community members aren't sort of feeling vulnerable for sharing their stories. We're making sure that we are always feeding back what we've done with their information and really showing the value that we consider that they provide us. So finally, the last key area is research. Research obviously sounds like a good idea, but it's so much more than that. We know that research directly affects policy, and if you're excluded from research, your policy changes happen and you're not included in those changes. So being included in research directly correlates with better health, and research active practices have better outcomes than those who aren't. And on our recent survey at the Deep End event, being a research active practice and a deep end research active practice has started to be something that GPs and newly qualified registrars are looking for when they look for a place of employment, which is a really brilliant marker for us of some of the success. We think about the research in 2 key arms. One of them is improving representation from these patients who are often underrepresented. And secondly, we want to make sure that their ideas and the ideas of our deep end clinicians are able to be amplified and developed into research ideas. So some of the key successes we've had here is through the RCF programme with Paul. So we've had frontline clinicians. A key success has been one of the menopause projects, looking at menopause care in women in South Bristol, and looking at how to improve their care, because they have some of the lowest rates of HRT prescribing nationally, which we know directly correlates with poorer outcomes, poorer employment, and less ability to cope in those years when those women are such pillars of the community still. We also have had successful work with the continuity of care RCF grant, which then went on to get an RCF type 2 grant, with the clinicians linking up with an academic at the University of Bristol, and also with the RCF programme and community members. And that has been a really successful project, working over several surgeries in Bristol, and then now working on a national toolkit for continuity, which has been, and talk with Ardens about trying to get that at a national level. So really brilliant things coming from a frontline non-researchers ideas that then can be scaled up to such a level. I mentioned a bit about the co-production from the community and how vital their input is. I also wanted to talk slightly about the amplified way we've had an opportunity to amplify voices of our lived experience colleagues. For example, Black Mothers Matter is a wonderful organisation in Bristol, run by two wonderful women who are very bright. And what happened at the beginning was there was offers from lots of other academic organisations to use their data, use their research, use their project, and potentially publish that. But actually, those women are very capable of doing that themselves. So through the deep end and through collaborating with our academic colleagues, we've able to put both of them have now had NHR pre-doctoral and applications put in, which are now being considered. And that is a really, just an illustration of how powerful this collaboration between all these individuals can be. We're also starting to work with other networks to try and do pan-deep-end collaboration, because if we can represent more of these underserved patients, we know that the outcomes will be better. This is just sort of explaining about where we're at. We want our patients to, our deep-end patients to, rather than be sort of a tokenistic afterthought, we need them to be at the grassroots, telling us what we need to be looking at and how we need to do it. We've had significant success in improving representation from the underserved communities. In the deep end, we now have 7 practices that weren't research active at all, which are now participating in RDN studies, which is obviously brilliant in representing the underserved communities. But all of this is only possible because of funded time for the clinicians to have to do the work, and also for the community to share their ideas. Relationship building has been the mainstay of this, and that's something that needs a long time and can't be done overnight. So I just hope that the key take homes that I can share with you are the idea that research is very possible in these communities, and we just need to make sure that they are properly supported and funded. Not only is it possible, but it is our duty to make sure that these patients are represented. They have the most amount of pathology. They have the most difficult life experience with social determinants of health that all of us would struggle with. They must be key participants in all studies. They cannot be an afterthought. With appropriate funding and relationships, it's very easy to make sure that they're involved. We just need to make sure these things are right. We need to make sure that research aligns with community need, and that the evidence we generate is actually then implemented, because these communities generally are sick of either nobody paying attention, or if somebody does, they then don't get feedback of how that data is used, and they can't see the changes happen. So I'm really grateful for BNSSG Training Hub, that the ICB, that NHR for funding us and for supporting us. And we really need sort of continued mainstream long-term funding to be able to continue our work, which I hope that you'll see is beneficial. Thank you for letting me speak, and I'd like to take any questions if there are any.
Okay, thanks, Beth, and thanks, Paul. So just the first question for me then is, you've presented the board today. You've got some of the most influential people in health and social care, if not the most influential people in health and social care, listening to you. What were you hoping to get from coming to the board today?
So I think, well, there's a few strands to that answer. We've only been running for just over 2 years, and I'm really proud of the steps that we've made and the relationships we've been able to build, and the level of projects that have been able to give back to the community, the fact that we've been able to show improvement in recruitment and retention in that time scale. My anxiety about it all is, as with all the funding, and I understand it's a difficult situation, what we would like is the deep end as a concept to built into the ICB as a system approach, an acknowledgement that this is a key way that we could approach both helping workforce through recruitment and retention, and also a solution to research. Often the GP is a key mediator between research and community. Lots of my patients, I've got a huge Caribbean population and African population. They generally do not trust institutions, but they trust me because they see me and they know me. And if I can say, you know, if I can break down barriers about research, they are much more likely to be involved and understand the benefits that they would receive. So it's, I guess, acknowledgement that we can use GPs as this mediator between research and participants, and also a plea that the GPs at the deep end should be considered as a mainstream funding opportunity, because really we're excellent value and have delivered quite a lot on not that much budget. So it's that's my main ask.
Thanks, Beth. And just
Paul,
I'll bring you in a second.
Okay.
Just one other question for me, because I asked Paul this question last week at the Health Inequalities Committee, because there was quite a lot of pushback there from people at the table about how they were engaged and how they talk. The question for me, and I sort of tabled this with participants here earlier on this morning, you know, we're quite strong around clinical and professional opinion in how we form policy, and we're not quite so strong on citizen and public voice and patient voice, but we're better than most. But the research element, we've got a fantastic, as you've described and as Paul's described, we've got a fantastic amount of research going on within our area in BNSSG. And you talked in your presentation about research affecting policy. What are the examples that you've got where you think the research has affected policy, where it's actually changed the way we do our business within BNSSG?
So one of the key examples I give is in prostate cancer. So looking at prostate cancer screening. So the national big piece of research looking at the prostate cancer screening in men. In that national piece of work, not one of the participants was a black man. Now, black men, 1 in 4 black men gets prostate cancer. 1 in 8 to 9, depending on what stats you look at, white men gets prostate cancer. So I totally agree with you that we're streets ahead in lots of ways, and there is participant involvement. And it's not a criticism of any of the people doing that engagement, because I believe everyone is doing it to the best of their ability. However, the patients who we are having are not representative. So, you know, like what Paul said, generally we have a middle class, tertiary, you know, that's another key example. A huge study that the King's funded looking at health literacy and documentations within healthcare. And there was a big piece of work looking at appropriate resources, leaflet resources. The study was done on all tertiary educated people. Now, the national age of reading in the UK is 9. The national reading age of estimated age, because it's not actually so specific to BNSSG, of our population is 6. Lots of my patients can't even write in their language of origin. So we have to do lots of work about using verbal rather than paper tools. So if you're trying to build a resource and you're not including any of the people who need that resource to be appropriate and ready for that, you know, it's essentially, it doesn't matter that you ask the patients, because if the patients are much more like us than they are the patient group that we're trying to serve and who are underserved, it's not really a meaningful engagement. So that would be sort of my answer to that. I think in regards to speed of which research changes policy, often that is slow and tricky, and that is a bugbear. We were Gail Morzetti from the Department of Health joined us at one of our Deep End events, and a lot of the questions from the clinicians were around the frustration that, you know, on average it takes 17 years between we know what to do from research and a policy change is implemented. By then we have newer research, and the whole thing is not a waste of time, but you know, a difficult to justify. And so there was a lot of pushback by, we need to change the levels of implementation. And actually she did go back and come back to us and say in her spending that she was going to change the amount, and she did change the percentage of implementation rather than actual research, because often we know what to do, it's just enacting that change.
Okay, thanks, Beth. I mean, I know as a board we're really keen to make sure that policy is based on evidence, and research plays a big part in that evidence base. So we're really keen to hear that, and I think our Health Inequalities Committee will shine that light on the perspective of different groups, which it doesn't always get the look in as you've suggested. So that's really helpful. Let me open up to board questions. So I've got Jaya first of all, then Steve, and then Fiona.
Thanks, Jeff. fantastic presentation. Really, really good to see what you're doing in terms of deriving good recommendations, a legacy of impactful recommendations from the evidence. And yes, certainly it's I guess the biggest challenge, as has been said by Jeff and you already, is the time it takes for these learnings to get embedded into policy. And maybe that's a research project in itself. I do wonder, because there is a challenge on funding, and it's a big challenge for everyone, whether or not you've already reached out to the VCSE sector, because there's a lot of work that's going on with BNSSG and our VCSE sector, and it could well be that there's a big link to explore between what you're doing in terms of research and ways in which the community should be supported.
Yes, thanks so much for that. Yes, a big part of our work, and the 15 community organisations I mentioned are all part of the voluntary sector. So establishing those links, looking at what pots of funding there are already available, and making sure that we are tapping in and using those as appropriately as possible has been a key part of this. In a lot of situations, we don't want to reinvent the wheel. Good work has been done. Good work continues to be done. Sometimes it's just about making sure that the people who need to be seen can be represented, or making sure that the links between our colleagues and are made. So, for example, lots of the advocacy work hasn't been about making any new schemes. It's been about making sure that the GPs and other primary care clinicians, for example, are aware of what schemes are available, so that they can appropriately signpost to the patient group, so that they are getting the best care. Because if you have really good digital literacy and all your family's from Bristol, and you have a car, you can access groups much more easily than lots of my patients who are we've got a big migrant population who often don't have any English and don't have any family. So the demographic means that your access to those things is so huge. So often it has been about linking voluntary sector with primary care rather than reinventing anything.
And
thanks, Beth. Thanks, Chair. Steve?
Oh, sorry. Am I able to come in as well? Sorry.
Yeah. Paul, raise your hands, probably the best, and I can catch you then, because I've got 27 people on the screen. So yeah, over to you.
Yeah. So on the 17 years, so the BNSSG ICB has the first embedded within a health system impact accelerator unit. This is dedicated to turning research evidence into practical steps that we embed into practice. And we've got a few examples of those already happening, and it's turned it from like the 17-year average down to, we had one project which was around GP support for patients with dementia from South Asian populations. Lots of resources and toolkits. We got that embedded into Remedy, into Ardens, so it's available for all practices within about 4 months. So we can do it if we put some dedicated resource to it. So we've got some dedicated resource, so we can do more of that. The VCSE sector, so we're working with a number of different VCSE sectors as part of our research engagement network, which is the other arm to our making sure we're targeting the greatest needs. And we've developed contracts which are, well, co-developed contracts which are suitable for voluntary sector organisations, which is nationally first. So they're being used as templates across the country now, which is great. And we are creating a scheme so that the unnoticed work which is required on voluntary sector organisations to be involved in research actually gets recognised and paid for at appropriate rates. Because what we've got at the moment is a system which exploits the goodwill of people who really care for their communities, and I'm adamant that that's not going to be the way we operate. Just wanted to come in with that.
That's heartening. Thank you.
Thank you, Paul.
Thanks, Paul. Steve?
So thanks, Beth, and thanks for the work you've done. I mean, a couple of observations. Firstly, the ICBs were established to reduce health inequalities. Primarily, that's what their function was. And we've done some great work, but it is difficult. And what I think you've just reminded us is, with relatively small sums of money, you can make a significant difference if it's targeted and focused. So I'm going to suggest that you might want to have a separate conversation, take this offline, because there's other parts of the system that are trying to do something similar. So at UE, we've got the Primary Healthcare Research Hub, which is trying to work at how do we do things differently. Second thing is, I chair the Health and Innovation Network for the West of England, which used to be the Academic Health Science Network, which worked with Black maternity, the very people you've been talking to. And we managed to get that supported, but more importantly, the scale and spread becomes the important bit. So how do you move it beyond one practice? How do you remove it across all practices? So there's some understanding and work there that's been done. And then finally, at the University Integrated Care Academy, which is right in that area that you've been talking about, the research, the workforce, and reducing inequalities. So if we take this offline, there must be a way of joining some of this up and sharing resource, especially given the work that you've already done. So well done. Thank you for reminding us that you can make a difference and we can support hard to reach communities. But more importantly, we can learn from them and with them.
Okay, thanks, Steve. Shane, I think that's probably one for you. That's probably one for you to pick up, really. Maybe as with Paul as well, about how we do make sure that we are not all fishing in the same pond, or if we are fishing in the same pond, we're fishing for different fish, not all fishing for the same things. So yeah, good point, Steve. Fiona?
Yeah, thank you. So hi, Paul. Hi, Beth. I'm Fiona. I'm the representative for the VCSE Alliance. We've got over 170 VCSE organisations signed up already, and we're still growing. Across the BNSSG, there's over 8,000 community organisations. Paul, I picked up on your point that VCSE organisations get very little research funding compared to our statutory partners. We'd like to turn that around. We've got a wealth of knowledge, a wealth of reach, and there's a lot to learn here. So, you know, Beth, I am absolutely blown away by your enthusiasm and your knowledge. And picking up on Steve's point, how do we connect? What we don't want to do is duplicate effort. We want to maximise the assets that are in our communities and the knowledge that are in our communities. We've got to be careful of language. I've heard people say over and over again, I don't live in deprived areas. I'm not hard to reach. I know where I live, just because other people don't know where I live. And also there's trust. I've heard this as well, that if we look at particularly in underserved communities, they're not registered with GP practices, they're not seeking healthcare provision because of the lack of trust. So working with our community organisations and our VCSE organisations is key here, because actually that's where they do have trust, and it's looking at the assets. So, you know, absolute commend the work. I agree with you that a little bit of funding goes a long way. We know that in the VCSE because we have a little bit of funding and we take it an awfully long way. But how do we combine our efforts for the best that we can do for all of our communities? And research, I've already raised this about research and data and the importance, and particularly at a community and local level. How do we take ownership of that? How do we maximise it? And how do we work together?
Okay, thanks, Fiona. Alison?
Sorry,
Beth, let me take Alison and
sorry.
Shane first, and I'll bring you back.
Thanks, Jeff. Thanks, Beth. Thanks, Paul. Excellent. I mean, excellent approach, excellent performance, excellent platform from which to build. I guess for me, just a couple of observations. I think we've talked about impact. Some areas in North Somerset and South Gloss are more akin to the areas in red that you highlighted in Bristol. So there's something about us representing the whole of BNSSG. So actually, it isn't just Bristol. Bristol's might be a great test bed starter, but as I say, there are some areas in North Somerset, South Gloss that may or may not be more akin to those red areas. I think, Beth, you talk about, and I completely agree, about trust and relationship with people rather than trust in institution and health services. And I think in that vein, there will be a lot of people where they don't have their first contact in primary care with a GP or any contact with a GP. So I notice you use the word GP and clinician interchangeably. Actually, we have nurses, allied health professionals, pharmacists, optometrists, dentists, etc., etc. So actually understanding which person or which profession can be that link as well in terms of building the trust and relationship. So it doesn't all have to go through a GP, because not everything goes through a GP now. It's GP led, but coordinated, but not all GP. So I think that's quite important. And I think the final thing is what what are the principles that you have learnt from the areas that you've worked in, which would be great principles in the areas that are also on the map, amber or green, because they're still the same principles, aren't they? So we want people even living in a green affluent area or an amber area. There will be some people within there who don't access the services. So what are the 2 or 3 or 5 things that you've learned from engaging with people in some of the studies you've talked about, for example, prostate cancer? How could that be replicated in the areas that don't come up as red on the map? Because that's probably where we should be aiming as well. So thank you very much. The more you share with us, the more maybe expectations we've got, but I think this is a great platform.
So Beth or Paul, I don't know if you want to come back in on either of those two
Yes.
points, and then I'll bring Shane in to finish this up.
Thank you. Yes, thank you so much, Fiona, and also Alison, for those points. Yes, I totally agree, and that's why I use underserved, not hard to reach. These patient groups are not hard to reach. We are not doing the work. It's not up to them, and the onus is not on them. And yes, so you're exactly right. Often, and I mean, it sort of alludes a bit to your point as well, Alison, often these patients are not running through the door of Charlotte Keel, to see a GP. There's often mistrust. Even in the GP surgeries, and the community organisations themselves are sometimes the place of safety, which is why, as part of the Deep End, we attend lots of these health events. So I was at the mosque, the Jama Mosque in Easton a few weeks ago, doing an event. The Chinese Wellbeing Society and Dekbal and Black Carers are doing an event next week, which is a health check day, where we have GP presence. Now, before, when we've had meetings with the community, there has been a lot of discussion, well, why don't we just embed a GP in the community and they can be at the organisation? But the problem is we need equity of healthcare, right? These patients don't deserve a sort of add-on. They need to be seen in the primary care where they can get access to, the best tests, investigations. They need to have the appropriate specialists. So what we're finding is a better middle ground is for one of us to be at these events so that they become familiar. They know, that actually maybe seeing the GP isn't as bad as they thought. That interaction already builds some trust. They see the dynamic and the rapport that we have with their trusted community colleagues, and then or friends. And then from that, we can say to them, because we're piloting at the moment a system where the voluntary sector can have direct access to email in concerns about patients, either about like raised blood pressure, lots of it's about dementia, so reduced GP COG scores. They have then direct access to our Deep End surgeries so that then they can email in that concern, and then the onus is on the GP, who will then contact them for an appointment, because we're finding removing that initial barrier of the anxiety of approaching the desk or making the call is significant. So I totally appreciate what you're saying, and why community hubs are so vital, but that's our thinking behind having a representative at those kind of community events, but then making sure that they do end up in primary care, because ultimately that is where the healthcare needs to come from. We're looking at changing from our roundtable discussions. There's been a lot of talk from communities about wanting GPs to not just be a place that you go where you're sick, and about reframing the idea about preventative health and uptake of screening. So we're doing more events. So we've got a child health day. We did a Somali menopause event. We did an online one as a collaboration where there was over 100 people attended. So there's lots of work to try and bring that trust and change the thoughts around the GP. Alison, just in reply about the BNSSG, yes, so our Deep End is all of Bristol, North Somerset and South Gloucester. So it includes, we use the index of multiple deprivation with a score of over 32. That's a sort of established score. So often we have got 3 surgeries within Weston-super-Mare, which are part of the project and are very engaged. We had a health and equality fellow there who did unbelievable work in his branch of peer health. He was at locality. They had no salary GPs at the time, and by the time he'd finished the work, they had 4. Because he did such brilliant recruitment, just a really inspiring person. And that was through lots of the Deep End connections. So yes, they're very much involved. I think in South Gloucester, they're actually, in regards to the index of multiple deprivation, they don't fulfil the criteria on those, but I totally agree with the idea that pocket deprivation also cannot be ignored. So there is significant pocket deprivation in other areas. We know this isn't blanket deprivation. Charlotte Keel, where I work, has got some of the poorest people in the city, but towards St Werburgh's, there's areas of gentrification. Towards Greenbank, there's areas of gentrification. So it's not like the whole of my population is deprived, in the same way that in Pembroke Road, some of my sex workers who used to live there have now relocated, and they are an inclusion health group who've got loads of challenges. So we were working before with the GPCB about how we can do shared lessons from the blanket deprivation to the pocket deprivation. So I'd really be happy to talk through that and share more if that was of use. Thank you.
Okay. Thanks, Beth. Paul, did you want to come in at all before I pass to Shane?
Just to say, really happy to work with VCSE Alliance on, because we've got all sorts of research support services across the whole, ideas all the way through to impact and everything in between, lots around all the boring bits, contracts, finances, and all these governance elements that we can support the voluntary sector with, but we're not doing all that much at the moment. So it'd be great to work with you, Fiona.
Thanks, Paul. Shane?
Yeah, just to sort of conclude, every time I hear Beth and Paul speak, I am hugely motivated by what you both have to say. I think actually what it just shows for me is that research and innovation is at the heart of the ICB and strategic commissioning, and it will stay there, Paul. I can assure you of that, because ultimately we can't be a great commissioner, we can't serve the population we need to serve unless we're doing the things that you are doing and the stuff that you have done, Beth. The second thing just to raise is today, obviously, the 10-year plan is launched, and I only got a quick look at it over when I was grabbing a sandwich at lunchtime. But actually, the reality of the neighbourhood health system, healthcare, is all written all over it. The learning we have to take from the deep end work into designing the neighbourhood health system of the future is blatantly obvious. Because actually, if our job is to create health systems that reduce inequalities and improve population health and people's lives, we must take learning from the Deep End project. And to that end, we must continue with the Deep End projects. So ultimately, I just say thank you. The timing couldn't have been more perfect, because it really just fits in the 10-year plan and what we have to do. And the work you've done, Beth, is just astounding. And I know it's not just you, and I know it's a network, etc., but it is you, because actually you're a real driving force in this space. So really excited. What a great way to learn from what you've done, because it makes a real difference, and that's what the ICB needs to be doing. So thank you.
Thank you both. Thank you for your time. And I think, as Shane has just said, this is a critical element of how we take forward strategic commissioning as we move into the new iteration of an integrated care board. So rest assured, how the hard work that you're doing lands itself in our decision making, it needs to be absolutely ingrained in the system. So well done. Brilliant. Thank you very much.
Thank you all. Thanks.
I think Beth was trying to say something. Oh, you're muted, Beth, I think. Can't hear you. Don't know what's happened. Oh, the volume's gone. I'm sorry. Okay. Thank you for your time. If you can get back in, I'll by all means shout out, but we can't hear you at the moment. I'll move us on if I can, because I know we're pressed for time. So People Committee, Jaya.
Thanks, Jeff. So 2 meetings of the People Committee focused on the ICB as an organisation, and we've had those, and we've covered business as usual as well as organisational change. This committee will continue to meet bi-monthly, and to support the remuneration committee as well as people-related decisions that arise over the coming months. As a result, the terms of reference have been updated and have been attached. I wanted also to highlight the ongoing and constructive engagement with the Staff Partnership Forum and Inclusion Council in support of organisational change. In addition, the Union Recognition Agreement has been developed to formally acknowledge the role of unions in representing employee interests during this period of change, which is obviously the way we want to go. Although the System People Committee did not meet in May, month 1 performance updates and organisational priorities were shared by partners and circulated via email. The next ICS meeting this month will focus on system-wide workforce risks and Q1 workforce performance metrics. Also, as part of ongoing efforts to harmonise workforce policies with Gloucestershire ICB, 2 key updates have been made to policies on the ring fencing and also paper protection. Joe, did you want to come in on any of this? Have I covered it all?
No, I think that's it, Chair, to be fair. And obviously a huge focus on organisational change and working alongside Gloucestershire colleagues.
Okay, thank you both. Any questions around People Committee? Rob?
Not a question, Chair, just an observation. I shall take the action to take the terms of reference because the People Committee is a formal committee of the board, and I shall make sure that the governance handbook is updated with those on our website.
Okay, thanks, Rob. And it is going to be a busy time over the next few months, as we know. So thank you. Finance, Steve. Finance, Estates and Digital.
Thanks, Jeff. So you've got in the paper usual reporting on our projections. You've got April, May minutes in there. The focus, although we're still projecting that we will land against our targets, that it is tough. So we're continuing to keep focus to make sure that we don't start drifting. It's early days in terms of where we are in the financial program. So if we can carry on doing what we've been doing to date, which is to do the deep dives, to work with the system, to make sure there are no surprises that are beginning to emerge so that we can take action. And that's an executive responsibility and non-exec responsibility. We should be okay. But I'm very conscious that obviously, because of all of the changes that are going on, focus might start to wander a little bit, and that's what we've got to guard against. And that, I think, would also apply to some of our other committees in terms of general performance. A couple of other things just to note. We are, of course, therefore looking down and continuing to do deep dives within organisations where we know that there are significant pressures. What we've done in terms of June meeting was identify continuing healthcare, which has been a risk in the previous years and also continues to be a risk. And we need to make sure that that is being managed and controlled. We have, on the back of the work that we've done around the capital requirements across our system, we've secured additional funding. So 70 million addition against our operations of 99 million. And that, in terms of capital expenditure, is now being rolled out. It's against risk-based approach. So all of the hard work that went into looking at our estates has informed where are our highest risks, how is that going to be supported by capital. We'll be monitoring the capital expenditure to make sure that we use it and not lose it in appropriate ways. So we'll be tracking that over the next few months. You will have seen earlier today the work that's been going on in terms of trying to understand the growth across our system in terms of housing and how we start to influence against the fairly large growth policies around housing, how we're going to interface and work to influence developers' investment in health needs, and that's both in terms of design and delivery, but also contributions that they may make to the NHS part of the system, as well as wider communities. And the other piece of work that we've been focusing on in June has been around making sure that as a system we are considering the national threats around cybersecurity and how we best respond against national threats as a system. And there's work that's ongoing in terms of how we ensure that we work as a system as well as individual organisations. And that's probably covered everything that takes us into this month, unless I've missed something, Sarah.
So I just said, Sarah or Deb, do you want to, anything you want to come in on?
So I just want to highlight, you've got the finance report there for information. From a system perspective, we are 1.7 million off at month 2. That was driven by some slippage on savings schemes at UHBW in month 1. In month 2, they did deliver their plan, but obviously we've got to make sure now over the course of the rest of the year that we can recover that position. We did look at that at Performance and Recovery Board, and took a lot of assurance from the work that's going on there. So, you know, obviously we know that it is a really challenging year, but we've got really robust processes in place to keep monitoring that. So feel relatively confident. The only other thing was just we have taken through FED the procurement policy, and that's now here just, you know, for the board for oversight. So yeah, that was it from me. Thank you.
Okay, thanks, Sarah. And that procurement policy, hopefully board members have had a chance to look at that as a appended paper. I think it's just for agreement here, since it's been through FED, isn't it?
Yeah.
Yeah. Okay, brilliant. Thank you. Deb?
Yeah, just to say, we're working on the cyber strategy, as are many areas. And the other thing is just to flag up that as a board, there is a seminar session planned in for November, which will take us through our responsibilities around cyber security and linked to data security as well.
Thanks, Deb. I think that'll be really helpful. Thanks very much. Any questions for so Julie?
Going back to the money on the risks, and I'm happy to take a conversation offline, but you talk about ADHD and autism and a query a risk of 3 million. Is that adults or children? I'm just conscious we're doing a lot of work on children, and I want to make sure we're aligned, that we're not inadvertently adding to risk. Or can you say a bit more about that?
Yes, of course. So it is adults, Julie. So this is particularly where there are various new entrants into the market, particularly on adults. In actual fact, that is a problem in that, you know, we know that we've got real challenges around some of our children's waiting times, but that isn't where we've got the new entrants. It's particularly in adults. This is an area where we are working with the national team, because there aren't national tariffs for this either, or national standards. So this is something where I think we do need to keep influencing that policy nationally.
Okay, thanks, Sarah. Does that answer your question, Julie? Yeah.
Yes,
okay,
thank
great.
you. Yeah.
Thanks very much. Anything else on finance estates or digital? Okay. Primary care, Alan.
Thanks very much, Jeff. This is a verbal update on Primary Care Committee that was on the 24th of June. I did say at the start of committee, but I wanted to repeat it here, that despite the very significant personal and organisational uncertainty, we're still receiving excellent papers and verbal updates at committee. And I am keen that as a committee, and I know others probably will as well, where we can support the prioritisation that Shane talked about earlier, we can do so and provide some umbrella cover and support in that respect. As usual, it's a risk-based approach. We started with the risk register. It was good to see updates on all the risks that we know and are familiar with around commissioning hub, about local enhanced services, about dental activity units. So there were no surprises in the risk register, which I think is always a good thing for an assurance committee. Regarding dentistry, we talked quite a bit about the strategy that we've received here at board, and we know there's a lot of interest at board, and committee monitors that on the board's behalf. And also so the strategic intent, but also the current performance, and you'll see in the highlight report, which Dave will allude to very briefly, there's some progress, but there's still a long way to go. So I think there's something like 46% of children in BNSS2 still aren't accessing NHS dentistry, and more adults as well. We know visible tooth decay in under fives. We know that we've got highest levels of oral cancer in Bristol and across the southwest. So we know there are still issues. So what we want to do as committees, make sure that we align the inputs and the intent of the strategy into the outcomes and the performance. So and committee felt that the risk around dentistry is akin to some of the higher risks that we talk about here regularly at board. It's dentistry and the provision of good dental access and treatment is a high risk for us. Health inequalities played a part in a good part, as it usually does, but there are a couple of examples in Primary Care Committee. One is the housing policy, which we saw earlier in the day, and the focus perhaps on health inequalities. But also in the stabilisation of dentistry and the discussion we had about whether the indices of multiple deprivation could be used in targeting stabilisation of dental access. So health inequalities playing a part. we saw the work that Primary Care Operational Group do in terms of a delivery machine that's got a big scope, and it gets through a whole chunk of work on behalf of the board, which we see regularly. Always excellent finance papers from Jamie Denton, really good year-end position, but just always really clear and high-quality papers. And finally, which has been included in today as an example for board, it is the first of highlight reports around 4 key areas around primary care. One is around general practice, the Access Improvement Plan. Second is around Pharmacy First, which hopefully board colleagues know BNSG is performing very highly on in terms of in the country. It's ranked #1 in the country. Eye care, so a focus now on optometry that board will realise we focused a lot as an assurance committee on dentistry last year for obvious reasons, but optometry is now becoming a legitimate and right focus, and also the dental strategy, and you can see some of the details within that. So just an example to the board of the highlight report that's been developed by Dave and his team that committee will help evolve, develop, support and challenge on. Dave, is there anything that you wanted to pick up on the highlight report?
I think you've picked up most things, Alison. I was just it is the first attempt we've had at it, and it as you can see, it's starting to replicate what we have through OQPM and enables us to track those key trends and those core metrics, including the metrics that we've set out in particularly our dental strategy. So as we move forward, it'll be really helpful in making sure the outcomes that we're getting are as we intended. Alison, I think the only thing that almost just an update on the report and on dentistry, one of our key operational plan standards is to increase our access to urgent care dental appointments by 19,000 through this financial year. At the point of the report, we'd gone out for expressions of interest for those appointments. So I'm pleased to say that we have had applications up to that 19,000, in fact, slightly over, and they are there will be additional appointments available in all of our 6 localities. So that is really great news. But because we were slightly over and we couldn't at the moment afford to go much over, we have used our Cambridge Mobility Score to target slightly higher access in those areas of greatest need. So we're sticking to our guns on our dental strategy commitment, but additional urgent care will be available in every locality.
Thanks, Dave. Thanks, Alison. Any comments or questions for Alison or Dave on the Primary Care Committee? No? Okay. So Paul Roy's done a lot of the work for me on the next one, on the Strategic Health Inequalities Committee. You've seen the minutes from the 14th of April. It had 2 sides to it, really. There's a lot of conversation in the committee about the changes and how that would affect the way we approached strategic health inequality and what would change there, and some concerns, really, which have been voiced throughout the board today. But rest assured, it was from a very positive perspective, not a negative one. That committee really does take a different perspective on things. So when Paul Roy presented the paper, which he's just done for us now, and a lot of the work that Beth presented, there was quite a lot of challenge came in from the group. And I think some of it was about how we identify people in Black and minority communities, particularly as community representatives. They go as advocates to do the research, and then they get a lot of negative response and feedback from people in the community about being responsible. And Paul has come away with that, recognising that methodology for research has to be really thought through carefully, rather than just allocating it to individuals and saying, you know, you're the community leader. It doesn't really work. And we probably saw that in some of the conversation that Beth gave us, which is it's not a them and us. It really is about a collective and the way that we do it, and one size doesn't fit all. But it was really, really good. And then what came out from that, which is probably replicated in the question I've asked a couple of times today, which is, if we're truly serious about the amount of effort we're putting into research, particularly in our most disadvantaged communities, then what are we doing with it? So you'll probably find that I had a similar response to when I asked that question to Beth there, which was, okay, so how are we landing this in our decision making? And it's probably not as strategic as we'd like it to be. So I think we probably need to think a bit harder about how we do that going forward, because we are doing such brilliant work, and in practical bubbles, it is probably quite effective. But the question Steve asked, which is, so how does that translate to us as an ICB, rather than just in pockets in general practice around our area? We have got some brilliant work ongoing. We need to think about how we scale it up, and we need to think about how we actually also challenge that data. So Steve talked about data being done in other circles. Well, where are we coming back together and maybe challenging some of that research? Because it isn't always fact. The fact that we've done a lot of work in it doesn't mean it's always going to be the best. So I think it's going to be a really even more important element of how we move forward. I think Shane has impressed that on us. But I think we need to probably think a bit harder. Now, we're not alone in this. I suspect nearly all of us have been in organisations where we've talked about using the evidence base, but if it's slow coming to us, then it ends up propping up a door rather than being at the centre of how we make our decisions. So we had a really good session in that, but there was a lot of pushback from participants about how you capture the community voice, particularly how you capture the community voice in the way you do your research. And I think Paul has brought that out for us today when he talked about 95% of people who engage in research are white and not necessarily disadvantaged. Fiona, do you have your hand up?
I did. Thanks, Jeff. I mean, I think that this is such an important area. I think one of the things is actually how do we invest in our communities so that they become the researchers? Because they're the experts. We are the experts in our own lives, in our own communities. It's not about them, it's about us. So how can we develop our communities as researchers? Also, I think that we need some transparency about the research that's happening, you know, in the various themes. So, you know, there's an awful lot of good stuff going on, but how do we connect it all up? You know, so there's, you know, I know that through the deep dive work, I was involved through locality and through peer health. But actually, how do we connect that up across the BNSSG, and how do we connect it up across, you know, the different themes? And then we can see where the gaps are as well. But I'm also going to say that's going to add resource and commitment and time and money. So, you know, it's chicken and egg, isn't it? But it's a really important area.
It is. And I don't think we've got all the answers yet, but it is going to be a central function to how we commission services. So of all the other stuff, this is very, very important. Deb's got a hand up as well. There was another input at Health Inequalities around digital that Deb gave, which I think went down brilliantly, Deb. I don't know whether you just want to mention some of that, because I'll steal your thunder otherwise.
Well, if you carry on, Jeff, I just wanted to flag that in the skim I've done of the 10-year plan, it is populated all the way through. So if you do your bit, and then I'll kind of pick up with that.
No, I think Deb ran a session and it sort of springboarded into the stuff that we talked around with cybersecurity and the way we head forward with that, but also talked about some of the stuff she's already presented to the board on where we are with our digital journey. And you are right, Deb, when you start to look at the 10-year plan today, that there's a significant chapter on the way that we start to embed the way we go from analog to digital, and how digital services will change the way that we do our business. Now, I know we all know that, but there really is a, you know, it's one of the key shifts in the NHS. But I think some of the work that Deb presented at the Health Inequalities Committee just reinforced that about how far forward we are on this, and we can't lose that as we go forward. So, Deb?
Yeah, and the core area of the focus was around digital inclusion, which of course it is one of the reasons that people experience health inequalities. So highlighting the government's plan, both for the NHS, but right across government and society, around driving up the capability, because we know if people are not digitally included, their ability to get a job, their ability to interact with all of the things that we're seeing in today's society, and obviously some of the things that are heralded in the 10-year plan. And digital inclusion is a core part of the delivery and actively mentioned. And it will be one of the things that in strategic commissioning going forward, we will need to ensure that we are commissioning for accessibility, both supporting people, our staff and our population, but also making sure that the things that we are commissioning from our providers are designed with accessibility, both from a physical perspective, but also accessibility from a digital perspective. So it may be, Jeff, that we bring that as a substantive item back to a subsequent board, so that once we've had a chance, as Shane was saying, to consolidate what's in the plan. I think some of the actions that came out of SHIP we can bring back, because it was about saying we need to make sure that we've got diversity reflected in this, otherwise we are going to be extending those health inequalities rather than closing down the gaps.
And I suppose it's no surprises really, but the questions that we get at the SHIP committee are very different, Deb, aren't they? They do get you to think, oh, yeah, well, that's not a perspective I'd have had, but they are different. And we shouldn't be surprised by that. But I actually think it will make us better at the way we deliver our services. So it was, you know, I think that group has still got an important part to play as we move forward. Any other questions on that before I move us on? Okay, John, audit and risk.
Right, thanks, Jeff. The pack has the April minutes referenced in it. I covered those in May. I just wanted to give a quick verbal update on the meeting of the 19th of June. So it was the final meeting with Grant Thornton as our external auditors before we migrate to KPMG. So I just wanted to record my thanks to Grant Thornton for their service over the years. The main business was focused on receiving the external audit opinion and approving annual report and accounts by a delegation that we had from this board in May. Shane was present as accounting officer to hear the reflections of the external auditor and was able to respond and give his thoughts, which was helpful. So I confirmed that the audit committee had private conversations with the auditors, had the opportunity to challenge and question the exec, and following this was happy to approve the annual report and accounts. Really good set of results that have been tracked via Fed throughout the year. And the process this year seems to have worked really well. And I was just kind of reflecting that in my time with the CCG and the ICB, I think this has felt like the smoothest year-end process, which I think is testament to the hard and collaborative work that has gone in. Excellent annual report, which showcases much to be proud of, and also an excellent head of internal audit opinion, and a good annual report from the counter fraud team to underpin the good work over the year. So my thanks really to all who have contributed to this outcome. We're keeping the annual internal audit plan under review given changes, but we remain of the view at this stage that it meets our requirements, but we've got flexibility if input is needed. And finally, I just wanted to flag data security and protection toolkit, which is a nationally mandated kind of scrutiny process that we've had to go through with the internal auditors. And at the time we were meeting, we were close to, but not quite compliant. But I'm pleased to say that we have now met the standards. It's a good outcome, and it is relevant to our journey, because it puts us in good shape around the data security of our supply chain as we move towards greater focus on strategic commissioning. So it was good to see that. So I'll leave it there, Jeff. Thank you.
Okay, thanks, John. And that, I mean, that is really good news. Both the internal and external audit for us are really, really positive. And I think you've shared that with board members, but it's thank you. And the work you're doing pulling that together is really, really positive. Any questions for John? Because I think a lot of us were probably present during that committee meeting, but anything for anyone else? Okay. Southwest Joint Specialist Services Committee. Shane or Sarah, the minutes have been circulated. Anything you want to add?
No, just to say this was obviously the first meeting post-delegation. There are a few things that I think, you know, we just need to pick up to make sure we get embedded, and particularly, Rob, I'll pick up with you, but making sure that we're thinking about how the flow of risks from specialist services can make it their way onto our risk register. So that's just one thing to highlight. There is work going on the sort of 5-year plan for specialised services. There was an update at this meeting, but we'll bring more information back as that develops to this to the board. So thank you.
Okay, thanks, Sarah. Shane, anything to add?
No, Sarah's okay. Representative on that.
Great, thanks. And then the Integrated Care Partnership update. Again, the last, Jenna Maris has picked up the chair now as the chair of the Health and Wellbeing Board from Bristol, North Somerset, and she is really keen and very enthusiastic that the ICP plays a significant part in what we do. Ironically, that's at a time when we may see some changes today with the 10-year plan around integrated care partnerships. But that group, I think, does play an important part in the way that we look at that wider sense of the way we deliver services. It really hasn't gained the same traction that the Integrated Care Board has, but still a lot of us are part of that. And there is a wider group of people, including a lot of your chairs across the organisations. So the last meeting tended to be about what does the future hold, because we didn't get a great deal of chance to do much more than that. But if there's anybody who's got any observations, questions, or just points of view on where we are with the ICPs, I think probably we've got to look at what our new structures look like and then what the 10-year plan is suggesting. And then I've sort of got to regroup with the chairs of the 3 health and wellbeing boards. But very much as I said in private board this morning, the push has been towards the regional mayor model and them having a much more significant role in what would be a health and wellbeing board. That doesn't necessarily fit with us because our footprint will not all be the West of England Combined Authority. So we'll need to watch that space, and I'll work quite closely with the 3 chairs of the health and wellbeing boards and the 4th one as we go into Gloucestershire or wherever that the new chair is in the new system. So any other comments or questions around integrated care partnership? No? Okay. So this is probably wishful thinking, he says, but my on Diligent, mine cuts off at item 14. I'm suspecting, Rob, there's 2 more agenda items below that, one AOB and one about public questions. Am I missing anything else on the agenda?
I'm just...
Because mine for some reason on Diligent is cutting off at 14.
That's exactly right, Jeff. On my version Diligent, you got any other business questions from the public?
The public as well.
So I've been doing this too long, haven't I? to know the agenda. So the first one, AOB then. Any other business from anyone else that we haven't covered? No? Okay. We haven't any questions tabled from members of the public. We've only had one member of the public with us today. So unless I see a show of hand or Rob or anything that you've seen coming to us? No? Okay. So it just remains for me to thank you and thank you for your time today. We've been at it since 9:30 this morning with a short break. I think we've covered an awful lot of ground and some really interesting stuff. I've given you an hour of your life back, but for those who can join the session at 4:25, which might be interesting around Penny Dash talking about the headlines from the 10-year plan, I think you might find that interesting. That said, I suspect we'll be talking about it a lot over the next couple of weeks anyway. If not, I look forward to seeing you at our next board meeting, which is, Rob, can you just remind me of that, and I'll bring Shane in, but can you remind me of the date? We got an extraordinary one, haven't we?
We've got an extraordinary one, I think 7th of August. That's closed and it's a single agenda item. And the next open board meeting is the 4th of September.
Okay, thanks, Rob. Shane?
The Penny Dash session this afternoon is 4:10, Jeff, not 4:25.
I had 20 half an hour I had in mind, but there we go. It's must have changed then.
On the email invite, it says
okay,
4:10. Do you know what? Join when you want.
Handy to have a chief. It's handy to have a chief exec covering your back, isn't it? Well, of those who can join us, you've got the LinkedIn invite. I looked earlier. There was well over 400 people booking onto it, so it's going to be quite a big session. But it might give us some information to start heading forward with the 10-year plan. But if not, if you've got a bit of time, enjoy the sun, enjoy the rest of the weekend, and I shall see you all soon.